Welcome to yet another edition of It's Your Health. Philip Benyo with Philip Benyo. We're bringing you the latest and greatest in healthcare information. We're going to be right back after this brief commercial message. Remember, you're watching It's Your Health, your leader in healthcare information. Make sure you check with your healthcare provider before doing any of the things that we mention here on It's Your Health. Be right back after this brief commercial message. Welcome back to the fastest half hour in television history. It is It's Your Health. I'm with my son, and we're going to start off with some pertinent headlines.
Well, we'll talk about statins. It's always a hot topic. Cholesterol drugs are linked to muscle and joint problems. Recent studies show that some people, we always knew cholesterol medications, particularly the statins, can cause some muscle aches or pains, but we're starting to see some bigger issues that we can actually have some joint problems or increased arthritis.
Right. Virtually everyone who takes a statin will complain to us that they just don't feel right on it initially when they start it. They'll have some aches and pains. Some will actually have charley horses. Some will stop it entirely altogether. But nevertheless, the good is going to outweigh the bad. So kind of stick with it, but report to your doctor about any muscle enzyme issues with the statins.
Let's get back to the statins and give them a plus now.
All righty.
Statins may cut the risk of hepatocellular carcinoma.
Yeah, that's an interesting topic that just came out. I mean, everybody's talking about the bad things of statins, but actually the good, I think, again outweighs the bad. What's the mechanism of this?
Well, they actually, remember, if we documented here on this show several years ago, there was talk of Lipitor cutting the risk of colon cancer, and there was research. The statins have a lot of anti-inflammatory qualities, and they help reduce a lot of cellular proliferation, which is sometimes one of the mechanisms for cancer. So there's certainly some studies now that show hepatocellular cancer, which is a type of liver cancer you see in people who have cirrhosis. And what's interesting, in people with cirrhosis, we would typically stay away from the statins.
Right, exactly.
Because you have to watch liver concerns with statins. But now they're starting to say, well, maybe we need to look at that a little bit differently. It's very exciting.
Right, and I guess maybe fatty liver might fall in there as well. Who knows? Because that's another thing that's kind of going around.
Moving along. Calcium supplements raise cardiovascular disease mortality in men.
Yeah, you know, we're always talking about vitamin D and calcium supplementation, and here we see that calcium supplements in and of themselves may not be good for guys. Now, we didn't say necessarily vitamin D, but the calcium might be an issue. So any thoughts on that?
Well, I think the problem is we used to recommend just a few years ago, take all the calcium you could need, you know, you'll just excrete what you don't need, and it turns out by having those increased levels of calcium, if there's any type of inflammation within the arteries, the calcium is going to tend to want to move to that area of inflammation. So it's going to lay down a calcium deposit in an arterial wall, which that's hardening of the arteries. That's not a good thing.
Right.
And so now we're starting to back off those recommendations, and you know, unless we see someone with low calcium, generally we let their diet take care of their calcium now.
And I don't see anyone, unless there's something really wrong with you, with calcium deficiencies.
No, it's pretty uncommon. For women, it's a little bit different, but again, even for women, we've backed down the amount of calcium we supplement. Vitamin D, that's a whole different topic.
Exactly, exactly. Speaking of different topics, tell us about some new medicines that we've uncovered.
Well, there's a couple of new medications. Let's talk about some medications we might see some specialists using. One is called Cimzia. Cimzia is a rheumatoid arthritis medication. It's indicated for moderate to severe rheumatoid arthritis. It is a injection. It's a type of injection you first get at your rheumatologist's office or at an infusion center. It's a simple pre-filled syringe. It's one of the exciting areas of growth. There's a lot of new medications. It seems every time we're here we're talking about a new rheumatoid arthritis medication.
And you know, it's unbelievable. When we were first starting out in medicine some 30 years ago when I was in my training, there was virtually nothing for rheumatoid arthritis except maybe prednisone. And here they really have growth arresting factors that can modify the disease. So someone who has a rheumatoid diagnosis out there, you really would do yourself a world of favor by seeing a rheumatologist and getting an update on what's out there.
I remember when I first started working, we would have a couple of patients that really had that real end-stage joint destruction, crippling rheumatoid arthritis, and I think with a lot of these new medications, we just shouldn't see people get to that point.
Right, they're disease modifying.
That's true. Moving on, let's talk about multiple sclerosis. There's a new tablet called Benyo, which helps cut down on the relapses, up to 50% of relapses for multiple sclerosis.
Again, another disease. 30 years ago, we only had prednisone. When you relapsed, you'd give people prednisone and they would tend to go back into remission, but prednisone, like water and fire, can be your best friend or your worst enemy. It can really have devastating side effects. So it's really unique to find disease-modifying medications out there. I'm not really sure how that works, or does anybody know how that works? Or
well, it's just I just think it's very interesting. Most of the medications we had for MS that would help cut down relapses were injections. A lot of people who have MS, they kind of try and fail a lot of different medications, and so it's nice to have another tablet to the armamentarium, and it's a tablet instead of an injection,
right,
which is a bonus.
Yeah, that's a good point.
Let's kind of get updated. You know, there's been, people are going to the emergency room. Normally we would admit them for blood clots. There's a lot of new things going on in the anticoagulation field. For 50 years we used Coumadin. Now, in the last 2 years, there's a whole advent of new medications. There's Pradaxa, there's Xarelto, there's Eliquis. How do we sort all this out?
Well, I have you to help me. I just had a patient who came in with atrial fibrillation last week into the office. In the olden days, we would admit him to the hospital, start him on heparin and then Coumadin, and 5 days later discharge him. I was able to give him a tablet right then and there. He was fully anticoagulated. Stroke and heart attack risk went down just by giving the one tablet, saved him a hospitalization. Maybe you could tease out for us these various medications.
Well, let's kind of put them into the classes for the indication. So there's a couple of different indications we anticoagulate for, and mainly it's atrial fibrillation, and that's an irregular heartbeat that can cause clots to form that can cause strokes. Pradaxa is indicated for atrial fibrillation. It's a twice-a-day medication. There's also another one called Eliquis, and that's the newest one to the market. That also is indicated for atrial fibrillation. There's a third one called Xarelto, and I believe this is the medication you used for that particular individual. That's not only indicated for atrial fibrillation, but interestingly, it's also indicated for blood clots. So a blood clot in your leg or a blood clot in your lung, normally a blood clot in the leg that's confirmed in ER, again, that's a 3 to 5 day hospitalization. Now it's here's your tablet and send you out the door. Now, there's some people you have to be really careful. Typically in the older population, these medications become less safe. But it's like the MS medications, like the rheumatoid arthritis medications, it's another cool thing that we have that changes the different paths we can go, whereas before it was just one set thing.
Very exciting, very exciting. And we talk about new medications. When we come back, we're going to try to touch base on how too much of a good thing is no good as well. Yes. How we want to avoid adverse drug reactions, particularly in the elderly out there. So concludes the first segment of It's Your Health. We're going to be right back after this brief commercial message. We are your healthcare leader in healthcare information. It's Your Health. Welcome back to the second fast segment of It's Your Health. Fasten your seatbelts and hold on. We're going to be providing you a lot of healthcare information, right, Fipster?
That's right. Let's get to some headlines, smoke through them, because we've got a lot of stuff.
Okay.
How do you prevent 1 million coronary events in diabetics?
It's very possible, and to a large degree, it's up to the individual. And it's back to basics again. You got to get rid of your smoking habits. You need to exercise a little bit more. And we're not talking huff and puffs kind of stuff. Maybe just take a walk 20 minutes 3 times a week. But what's crucial is that you get aggressive management of your diabetes in and of itself. Throw in a statin to make sure that the lipid profile is also going to protect you, and make sure that blood pressure stays as low as you can tolerate it. The use of a statin to keep your cholesterol down, keeping your sugar down, and keeping that blood pressure down will pave the way towards greater longevity, less side effects of your diabetes.
I think the key is, the take-home message is, it's not enough to get to your goal, but you have to get well below your goal. If you get to your goal, we can cut that million, maybe at about 500,000. But if you get below that goal, that's an additional 500,000 deaths we could prevent per year.
Yeah, that's amazing. That is amazing.
Now let's talk about heart failure. What are the best beta blockers for heart failure? There's a lot of different beta blockers. There's non-selective, there's selective, there's just a whole cornucopia.
Right. I think there's two that come to mind. One is Coreg, and one is metoprolol succinate. I don't know if that comes into your category. Those are the two that come to mind. You may think of others. But beta blockers, when, again, I was learning medicine, were virtually contraindicated. That is to say, we would never use them in heart failure because it was felt it would make it worse. But in point of fact, these particular beta blockers will actually lessen relapses of heart failure, which unfortunately is very common. So the two are?
Well, the two would be metoprolol succinate, which is also cotoprolol, but the one that really shows out and shines is Coreg. And Coreg's unique because it's actually like three medications in one. It's two beta blockers and an alpha blocker, and they find that that actually has some very positive effects on the cardiovascular system that cut down. You know, the use of atenolol, the use of bisoprolol, the use of a lot of these older beta blockers that are not quite as selective, those are the ones we have to try to get away from. And once you have that heart failure diagnosis, you owe it to yourself to be on something that's really designed for that.
Good point. Well said.
Glucosamine supplements tied to eye risk.
Yeah, this one kind of floored me because we run into a lot of people who have, you know, joint aches and pains, and they want to take glucosamine chondroitin sulfate to increase the cartilage in their system and cut down on arthritic issues. But
it also increases their intraocular pressure, so it increases the risk of glaucoma. So now we're going to start backing off some of the glucosamine, and for people who really love their glucosamine, maybe it's important that they're getting a yearly eye exam anyway. You know, the glucosamine, I found that in a very small subset of patients it might help. You know, I used to say, well, the worst thing it'll do is not do anything. Well, it turns out it might do something.
Right.
So now we're trying to get away from it.
Speaking of eyes, we had a call and a patient who had thought her eyes were blurry. Maybe she was getting a cataract. She noted some central vision loss, if you will. What would you do in a patient like that?
Well, usually any type of eye problem, you definitely have to refer to an ophthalmologist or an optometrist so they can get a proper eye exam. One of the things we're finding more and more is, or we're hearing more and more about, is macular degeneration or age-related macular degeneration. To lump it briefly, there's two basic types. There's wet and dry type. The dry is the more insidious onset over time. The wet type we typically see in diabetics. That's when there's bleeding from the vessels. There's a lot of new different medications out for this. There's a lot of interesting eye injections that are being done. It definitely is something you shouldn't just sit back and let it happen and say, oh, I'm getting old. There are some things we can do, but really it's about catching it early.
Right, and if you want to lower your risk of macular degeneration, believe it or not, you can. Again, let's get rid of the smokes. And they say, eat a rainbow. What does that mean? That means you want to get colored vegetables into your diet, peppers, green things, red things. If it's a veggie and a green and red, it's going to lower your risk of macular degeneration.
Let's talk about meds in general and reducing the risks of some of the effects. As we talk about all these meds we can give you, at the end of this show, you're going to think you need 20 different medications. And for a lot of people out there, they're taking a lot of different medications. And at what point is it too much? And at what point do we start having, you know, one medication treating a side effect of another medication, or we have a problem with medications interacting, or as we age, medications become somewhat less appropriate?
Right. Well, in this particular instance, less is more. And I don't think a week goes by where we try to go through a list of patients' medications. And it's not the patient's fault. They're seeing 3 different doctors who are throwing 3 different things into their soup. And so it's very easy to get into what we call polypharmacy, and we end up treating side effects of drugs with more drugs. Again, what we like to do is put everything in a brown bag, bring it down to your doctor, and we can sort out what you need and what you don't need. And don't forget, herbal agents are just as important because they're drugs and have drug activating agents. And Phil's right, as we age, the clearance of these medications differ from our liver and kidney, and the volume of distribution also changes with age and time. So too much of a good thing is certainly no good.
Moving on.
Yes.
Are you a mosquito magnet?
You know, I used to be. I don't know what happened, but I used to get nailed by mosquitoes all the time. And I found out when I worked out and I was jogging a lot, I got bit more. I got bitten more. The mosquitoes liked me more. So any truth to any of this?
C-spot run. Well, there are some people, most mosquito-prone people, it's actually genetic. It has a lot to do with the way their body processes cholesterol. People who process cholesterol faster, they have byproducts of cholesterol, typically layers in the skin. The mosquitoes love that. There are certain fragrances or things that people put on that help attract mosquitoes. Also, people who are typically exercising. You know, you're blowing off more carbon dioxide. Carbon dioxide are what attract mosquitoes. When you exhale, and the more you exhale, or the more carbon dioxide footprint you have, you know, on this earth, the mosquitoes will like you more. There are a variety of different ways that you can do it naturally, try to prevent mosquitoes and keep them away from you. There's also some other, you know, not so natural things, or the sprays, such as DEET and the like.
I'm probably just going to have to wait till winter. And again, maybe not exercise as much, but it finds out when you're sweaty and you get that carbon dioxide, you ended up getting hit more.
Yeah, it's important in our area too. We've had more mosquito-related problems. We've actually even had a couple of cases of West Nile reported.
Right.
When you look around and you see a funny-looking mosquito and it looks like a tiger, that's an Asian tiger mosquito, and those have a high incidence of West Nile virus. And so it is important to try to avoid these things and do our best to avoid mosquitoes as best we can.
Yeah, somehow I recall eating garlic as being one of those things, because garlic can get
I think you just like garlic.
secreted in your skin. Hey, another quick segment of It's Your Health. We're going to be right back after this brief commercial message. Thank you for joining us. Remember, you're watching It's Your Health. We're your leader in healthcare information. Be right back. Welcome back to the third and thank goodness final segment of It's Your Health, the fastest 30 minutes in television history.
We should have an online fourth segment, you know,
right.
a little special edition. But let's keep with the third. Let's get on to some headlines. We can smoke through them. Fish oils help cut diabetes risk.
Yes, well, fish oils, omega-3s, you know, you're kind of singing to the choir here. We love fish oils and what they do. What's the role here in diabetes, Phil?
Well, what fish oils do is they actually help increase a hormone called adipotin, I believe it's called, which helps increase insulin sensitivity. And so one of the key problems with diabetes is insulin resistance. So if our body cells are more susceptible to insulin and what it can do, our diabetes risk is cut.
Right, and don't forget the anti-inflammatory effect that these medications have.
Moving on, chronic heartburn may raise risk for throat cancer.
Yeah, well, we know that acid reflux can come up and irritate the lower esophageal sphincter area, turn into a Barrett's esophagus, if you will, which can give rise to cancer in that area. So how does it get up to the throat area? Same thing?
Just the chronic irritation. Those acids can silently come up and burn the upper part of the esophagus and the larynx. You know, it's part of the problem with some of the over-the-counter medications. A lot of people are kind of self-treating now because these medications work really well, but maybe they're not getting screened properly for esophageal cancer. Maybe they're not getting scoped. I think the general rule of thumb is, you know, what I like to do is I'll start people on a medication, I'll have them take it for a couple of weeks and then stop it. If their symptoms come back, they need to get scoped because something else is going on. It's not just some simple inflammation. You know, there probably are some chronic cellular changes.
Right, good advice.
Alrighty, lastly for the headlines, diet soda habit, bad for teeth, just as bad as meth addiction.
You know, I was kind of surprised about this, Phil. You know, people who have high acid contents that are out there doing crystal meth, you can tell right away when they smile because there's like no teeth. But diet sodas are doing the same thing? Well,
not only diet, but regular sodas. It has to do with the high acid content, the high amount of citric acid and phosphoric acid, which is a very powerful acid. They really look, these are calcium-seeking acids, so they're going to look for the nearest source of calcium. And as you drink that, where's the nearest source of calcium? That's your teeth.
Right.
And dentists are starting to have fits, you know, because there's a lot of increased tooth decay for people who are drinking modest. I'm talking a liter or two of soda a day, you know. And if you put up a smiley face of someone who's on crystal meth and someone who uses crack cocaine and someone who uses soda, They kind of look the same, and that's kind of spooky.
Yeah, it is, especially for our youth. So dial it down.
That's right. What are we talking about next? Shingles vaccine?
Yeah, let's do the
Human
shingles
papilloma?
vaccine.
Okay.
It should be a no-brainer. Adults out there, even if you've had shingles, should consider getting the shingles vaccine. Sometimes it's paid for by your Medicare Part D, but speak to anyone who's had shingles and the pain that it can leave you, and they will have wished they had gotten the shingles vaccine. Very safe. We've not seen any side effects from that. You can't get it, if, for example, if you are getting chemotherapy or have an immune system which is not 100%. That's generally the biggest thing we would advise against it.
Yeah, I haven't had really anybody that I've said, no, you shouldn't get this. It's approved for over the age of 50. Insurances typically cover it, 50 to 60, 60 and above. Definitely should talk to your healthcare provider. It's a one-time shot. There's no boosters yet. Definitely worth
looking into. It really is. Now, speaking of vaccines, and I know some people are out there saying, oh, these vaccines cause this and they cause that. But in point of fact, I think they prevent infinitely more things than what is said they cause, if you will. So now the biggest headline, of course, is human papillomavirus, HPV. Phil, I'm going to ask you some questions about this. What is HPV?
HPV stands for human papillomavirus. It is the most common STD in America right now. HPV virus is a typically completely symptomless STD. Guys out there that have it, girls that have it, more than likely you don't know you have it. At any point in time, more than 50% of America right now has at one point had this virus. Women are getting screened for it once a year when they go for their Pap tests or see their gynecologist. They're able to do screening to look for HPV. And the reason is the increased risk of cervical cancer. Cervical cancer in women is the second leading cancer death. And so HPV helps equate for almost 70% of these cases. So it's important now that we have, before 5 years ago, we didn't have anything we could do for HPV. It's just, there was no prevention really, but now there's things we can do. There's vaccine.
Right. Let's talk about that. What is the HPV vaccine and why get vaccinated?
The HPV vaccine is Gardasil. It covers 4 different subtypes of HPV, which are the most common types of cancer, both cause the most common types of HPV-related cancer in both women and men. And that's the other thing. That's the rub. Is now we're talking about men. We used to just talk about women for HPV vaccine or Gardasil, but now it's approved for boys because we're starting to see certain different types of penile cancer. We're starting to see oral pharyngeal or laryngeal cancer, and there's been some notable people in the media that have been talking about this. Again, a symptomless disease. The STDs of years ago, they caused some burning and you got an antibiotic. Now they cause cancer. They're much bigger.
Right. So check with your doctor, HPV vaccine, and we're starting to give it more often, of course, to our younger crowd as well, right?
The real key is you got to get this vaccine before anybody's sexually active. And there's this kind of the veil is that parents say that, or some pundits will say that by giving a vaccine, we're going to have our kids have sex more often. And, that's not what this is about. This is about preventing cancer. And so we have to take some of the stigma away from this vaccine. It's a three vaccines. You get it 1 month, or 0 months, 2 months, and 6 months. Definitely worth looking into for your kids out there, and for those of you who are still not sexually active, definitely worth looking into.
Right, and with summer upon us, Phil, let's put up a list here of the sunscreens, which we talked about earlier with my bride on It's Your Health. But here are some of the leading sunscreens which we would offer to you as being safe and effective. Again, you want to put a sunscreen on even before you get outdoors to begin with. Use it liberally and often, for example, every 2 hours, for example. You want to look for ones that perhaps are water resistant as well. And stay away from sprays, particularly in a kid. Sprays and kids don't get along. But Phil, any comment on this?
No, I think it's important. You do it early, you do it often. And if you're already out in the sun and it's been 2 hours, you're behind the 8 ball. It doesn't mean you shouldn't put it on, but you should have put it on before you left the hotel or you left your house to go outside. You really are supposed to put it on a good half hour before you're exposed to the sun.
Do it often. That's what watching It's Your Health will, our recommendation is for sure. Thank you for allowing us to come into your homes, entertain, and hopefully inform you. You remember, you're watching It's Your Health, your leader in healthcare information. Thank you.